Welcome to today's Explainer. We're going to act as medical detectives today to uncover the mechanics and critical pathways of acute kidney injury, or AkI for short. You know, our kidneys are essentially the body's magnificent filtration engines. But when they suddenly fail, the systemic consequences are rapid and honestly, potentially fatal. Our goal today is to equip you with the exact clinical logic you need to crack the case when your patient's renal function just suddenly plummets.
Okay, let's quickly check out our investigation board for today. We'll logically track down the causes, symptoms, and life-saving treatments for sudden kidney failure. We're going to start by defining the threat, move through our prime suspects and bedside clues, analyze the lab evidence, and finally, look at exactly how we intervene both in the hospital and at home to save a life, capping it all off with a real-world clinical case.
All right, Section 1. The crime. What exactly is AkI? Let's define the injury and figure out exactly who it strikes.
Now, get this. A massive 10% of all hospital admissions are affected by AkI. That makes it an incredibly common and frankly dangerous clinical enemy. We're not talking about some rare, obscure condition here. If you're walking the wards, you are going to encounter AkI constantly. It's essentially a sudden, often reversible loss of renal function that develops over just days or even weeks, completely throwing off the body's fluid and electrolyte balance.
So who are our most vulnerable victims? Well, older patients and folks with pre-existing conditions like chronic kidney disease, diabetes, heart disease, or liver disease, they face a heavily compromised renal reserve. You see, as we age, our nephrons just naturally decline in number. So a minor insult, say a bout of dehydration or a new blood pressure medication, while a younger kidney could easily shrug that off, right? But it can push an older, compromised kidney straight into acute failure.
Okay, so how do we actually confirm this crime? We're looking for a sudden spike in blood creatinine over 48 hours or a dangerous hourly drop in urine output. Creatinine is just a waste product from muscle breakdown that healthy kidneys constantly filter out. If that spikes by more than 26 micromoles per liter within just 2 days, or if your patient's urine output drops below 0.5 milliliters per kilogram per hour, the alarm bells should absolutely be ringing. At that point, the kidneys have officially stopped doing their job.
Moving on to Section 2, the suspects. We group AkI into 3 main causes, based on where the primary failure actually occurs.
If you think of the kidneys as the body's primary filtration engines, functional problems can happen before the engine, intrinsically inside the engine itself, or downstream after it. This anatomical map right here is going to be your best friend. Pre-renal just means the blood supply coming down the renal artery is compromised. Renal means the tissue of the kidney itself is damaged. And post-renal? Well, that means there's a plumbing issue, basically an obstruction in the ureters or bladder that's preventing the urine from getting out.
So if systemic blood pressure drops, the engine literally starves. That's our pre-renal state. Pre-renal AkI is heavily tied to volume depletion. We're talking severe vomiting, hemorrhage, or even heart failure where the pump just isn't pushing blood to the kidneys. Post-renal, on the other hand, is entirely different. The kidney is making urine just fine, but the exhaust is physically blocked by an obstruction, like a swollen prostate, a kidney stone, or a tumor. That creates a dam, causing pressure to back up and crush the delicate filtration system. Now, what if toxins hit or intense inflammation occurs right here in the glomerulus? Well, the engine essentially breaks from the inside out. We clinically classify this as intrinsic renal failure, and this is our third suspect. Here, the internal machinery, like the delicate capillaries of the glomerulus or the renal tubules, is directly injured. This can be caused by prolonged ischemia, nephrotoxic drugs, or even autoimmune diseases that directly attack the kidney tissue.
All right, on to Section 3, the clues. With our core suspects identified, we have to actively hunt down the physical clues by spotting the clinical signs and symptoms of AkI right at the bedside.
When the kidney fails to clear water, the effects are absolutely devastating. Just look at this chest x-ray. Pulmonary edema has completely flooded the patient's lungs. You see, when the kidneys stop filtering, all that fluid has to go somewhere, right? It backs up into the vascular system and spills straight out into the alveoli of the lungs. The patient will present with severe shortness of breath, and you'll hear crackles when you listen to their chest. It is a true medical emergency. Beyond fluid backing up into the lungs, you've got to watch out for severe oliguria. That's low urine output. Also look for signs of profound volume depletion, like a racing tachycardic heart and dry mucous membranes, or even neurological confusion caused by uremia. If the AkI is pre-renal, the patient might look incredibly dry.
But on the flip side, if their kidneys aren't clearing waste, toxic levels of urea build up in the blood. That leads to uremic encephalopathy, which manifests as confusion or, in really bad cases, even seizures. Oh, and don't forget to check for sacral or ankle pitting edema.
Now for Section 4, the investigation. Once we spot those physical clues on the ward, we've got to head straight to the laboratory to lock in our diagnosis with some lab tests. So, a really crucial diagnostic step here is separating pre-renal states from intrinsic acute tubular necrosis. This is absolutely fascinating. In pre-renal AKI, the kidney is healthy, but it's starving for blood, so it wildly hoards sodium to try and retain water and boost blood pressure. That's exactly why urinary sodium drops below 20. But in intrinsic renal AKI, the tubules themselves are dead or dying. They physically lose the ability to hold on to sodium, so it just spills out into the urine, pushing the concentration way above 40.
You know, even a rapid bedside urinalysis dipstick provides vital clues. It helps us detect hidden blood or protein that firmly points to a direct inflammatory attack on the kidney's filters. If you see high levels of protein and blood on this simple dipstick, you can pretty much point your finger away from a simple dehydration issue and start looking toward glomerulonephritis or a severe tubulointerstitial disease. It's literally a rapid, non-invasive window right into the renal tissue.
Section 5 is the intervention. Armed with a precise diagnosis, we execute our game plan by exploring hospital treatment protocols and, importantly, the transition to home management.
Let's talk about renal replacement therapy, or RRT. This is an advanced intervention where the intensive care team brings in a specialized machine, like hemodialysis, to externally support or completely take over cleaning the blood when the biological engine completely stalls. Now, we don't jump to this immediately. But if a patient has severe fluid overload that just isn't responding to drugs, or if dangerous potassium levels are threatening their heart, RRT becomes a life-saving bridge. A large catheter is inserted, and we manually filter out the toxins and excess volume until their own kidneys can, hopefully, recover. Alongside possible machine support, hospital teams will aggressively optimize fluid levels. This is the bread and butter of AKI management. You really have to thread the needle here. If they're hypovolemic and dry, you give them fluids like balanced crystalloids to prime the pump. If they're overloaded and their lungs are filling with fluid, you push high-dose loop diuretics. You instantly stop any nephrotoxic drugs, and critically, if their potassium spikes and causes severe hyperkalemia, you immediately administer intravenous calcium gluconate. Actually, scratch that. The calcium doesn't lower the potassium, it stabilizes the heart muscle to prevent a fatal arrhythmia while you work on clearing the potassium out. And once stabilized and discharged, home treatment becomes paramount. We're talking strict fluid monitoring, careful diet management, and completely avoiding over-the-counter painkillers like NSAIDs. Now let's look at the prognosis pathway, tracing the patient's future from day one. We start with the acute insult and oliguria, move through a massive diuretic phase in the days to weeks following, and hopefully reach a full recovery of renal function in the coming months. What's vital to know is that as a patient's kidneys start to recover, they often enter this massive diuretic phase where they can excrete liters of urine a day. You have to carefully monitor their fluids during this period so they don't swing right back into dehydration. While many do fully recover, older patients or those with severe injuries are at a much higher risk of progressing to chronic kidney disease or end-stage renal disease down the line. All right, Section 6, the case file. Now it's time to put your newfound diagnostic skills to the test with a real-time case discussion pulled directly from clinical practice. Here's the scenario. A 65-year-old patient with a severe SARS-CoV-2 infection develops sudden acute kidney injury. So, what is the most likely pathological mechanism behind this failure? Think about our three suspects here. If a patient is fighting a severe respiratory virus and develops AKI, what is actually breaking their renal engine? Think about the systemic effects of a severe viral infection: the drop in blood oxygen, the intense immune response, the potential for microclots. Which part of the kidney is most vulnerable to this specific kind of chaos? Got your guess? The definitive answer to our medical mystery is acute tubular necrosis, or ATN. It's a form of severe intrinsic renal damage. Basically, the massive stress of the illness, combined with systemic hypoxia, effectively choked out the most demanding cells inside the kidney.
The textbook explanation here is actually pretty fascinating. It says the tubular region of the kidneys is most susceptible to injury due to the relative hypoxia at baseline in the medulla and the high oxygen demand of the tubules. To put that into perspective, these tubules are doing the heavy lifting of actively transporting electrolytes back into the blood. That requires massive amounts of ATP energy and therefore massive amounts of oxygen. But they sit in the medulla, a part of the kidney that just naturally has a lower oxygen supply. So the moment systemic oxygen drops during a severe illness like COVID-19, these tubular cells are literally the first to suffocate, die, and slough off, physically blocking the microscopic plumbing and causing that acute tubular necrosis.
As we close out today's explainer, I want you to ask yourself, will rapid clinical detection save your next patient's kidney engine from irreversible failure? How could mastering these distinct diagnostic clues early on completely change their survival trajectory? We've seen today that acute kidney injury isn't just a single event. It's a dynamic crisis with distinct causes, from a starved renal artery to suffocating tubules. By spotting a sudden rise in creatinine, recognizing the physical signs of fluid overload or dehydration, and rapidly deploying targeted hospital and home interventions, you aren't just treating a lab value, you are rescuing a vital biological engine before the damage becomes permanent. Until next time, keep investigating, keep questioning, and keep learning.